open disclosure is fundamentally key to what we are trying to achieve as a public health service. If you look at it from the patient's perspective, it's about respect, accountability, it's about transparency, but from a patient perspective, it's also about confidence. So the public really needs to have confidence that their health system that they attend has appropriate clinicians, safety mechanisms, policies and processes in place that really deliver and continue to deliver safe care. We work hard behind the scenes to try and get that message to patients, whether it's information that's scattered around the health service or even in brochures that are given to patients on admission. I think fundamentally we try and get that message so it's there and it's in the environment, but we're also about empowering our staff to feel confident at all levels that open disclosure is a natural part of delivering safe, high-quality healthcare. It's not in high complexity cases it can be a special event, but usually we try and instruct our staff to integrate it into their business as usual everyday care, so that if there is an issue with delivering care, even in a small way, that they're confident and comfortable in that open disclosure process. And that whole culture then infiltrates the way the organisation works and the way the staff work. Fundamentally, I think it's about modelling behaviour. So particularly in a teaching institution where you have a variety of levels of staff, whether it's in nursing, allied health or medical, and you've got clinicians in training, but the seniors need to model good behaviour and good practice in terms of open disclosure. So as well as having the formal policies and procedures in place, teaching and training of senior staff, but also of junior staff, and incorporating them in that open disclosure so that again they can I suppose mimic and model on best practice that they observe in their everyday clinical lives. So I think it's about modelling and being true to the principles of it, which is again about respect and transparency and accountability. I'll be the first one to admit that clinicians sometimes they're time poor, but they're often time poor. They're busy, and they're keen to move on with their care delivery. So behind that is we at Austin we call it our clinical risk team that are there to support and I suppose almost coordinate, particularly the more complex cases, the delivery of open disclosure. So it's done in a way which is true to best practice in terms of policies and procedures, but it's also done in terms of making sure that we're coordinating the patients, their families, and their carers, and the staff as well, because it can be, particularly in a more complex case, a very tricky thing to get the timelines right. But also respect the need to support patients and family and staff through what is a very challenging process sometimes. So we do have a team which works with the clinicians to deliver that in an organised way. I think the other key thing to deliver it in an excellent way, in a best practice way, particularly again for those complex cases, is preparation. So pre-meetings where we assign a coordinator, we develop timelines, everyone's on the same page. That's so important in just getting the practicalities of open disclosure done, but also in giving that confidence to the family and the patients that the health service actually knows what it's doing, because there's nothing that looks and undermines the confidence of the patient and the family if they see that there is disorganisation in what is a very sensitive procedure or process sometimes. So I think the pre-planning for complex cases is vital. Now there are cases I think which happen in day-to-day life which might be the low-level 3s and 4s in terms of risk rating that can be managed very succinctly by a senior NUM or a clinician at the bedside, and that's a little bit of a different process than what I'm thinking about in the more complex cases. Yeah.